I'm just going to go through the blueprint, whatever's on it. Let's see. First thing is pelvic inflammatory disease. So I'm just going to go to wherever that section is. Okay. So pelvic inflammatory disease is a sexually transmitted infection because it is caused from sexually transmitted infections like gonorrhea and chlamydia. So it's an inflammatory condition of the pelvic cavity that may begin with cervicitis, so inflammation of the cervix, and then it can involve the uterus. So remember that the inner lining of the uterus is called the endometrium, so that's why it says it, inflammation of the endometrium. And then the fallopian tubes are also having inflammation, and the ovaries as well. Pelvic peritoneum or pelvic vascular system. So with PID, sexually transmitted bacteria spreads from the vagina to the uterus, fallopian tube, and ovaries, and this can lead to infertility as well as sepsis and death. So key complication. So PID is a key complication that can result from chlamydia or gonorrhea infection, but mainly it'll happen if chlamydia and gonorrhea go left untreated. So yes, gonorrhea and chlamydia are sexually transmitted infections, and they are the common cause of pelvic inflammatory disease. The most cases are associated with more than one organism. So chlamydia and gonorrhea are sexually transmitted bacterial infections that left untreated can result in PID. So PID is mainly a complication if you're not treating that sexually transmitted infection like chlamydia or gonorrhea early on. So the main thing that's going to happen with these patients is that they're going to become infertile, or if they're pregnant and they have PID, then preterm labor complications can happen as well. Preterm labor complications, the baby's lungs aren't fully matured yet or anything like that. Fetal demise, things like that. Let's see. These infections are typically asymptomatic, which means people do not know they are infected and unknowingly infect other people. So usually early on with sexually transmitted infections, people do not know that they have it. But once it goes untreated for a long periods of time, then we'll see those symptoms. We'll see that discharge, that painful urination. The main thing with symptoms of PID is that you're going to see lots of discharge from the vagina or penis because this can affect either gender. And then dysuria is just a fancy word for painful urination. So the patient could possibly have symptoms of PID, which include pelvic pain, so pain down there. So all of the symptoms do make sense. Diagnostic test. So what are we gonna test are we gonna use to help us diagnose PID? A urine test. We can also collect a specimen by swabbing the female cervix or the male urethra. For a look at the type of bacteria. Treatment, it is an infection, so we're always going to treat with an antibiotic, usually like doxycycline if it's chlamydia, or cephalosporin if it's gonorrhea. So it just depends on what the causing organism is. Nursing care, you want to complete disease reporting requirements, as these are reportable infections. Reportable infections like to the state, just depends on the state. Just because you don't want, since it's reporting, you need to report it so that it doesn't go left unsaid. And so, the person who has it has to also let all their partners that they have had sexual intercourse with know that they have it. And then during treatment, this patient needs to be abstinent, which just means that they're not supposed to partake in sexual activity. That's what abstinence means. Partner notification and treatment. The partners that they've been sexually active with also needs treatment, just because PID is associated with death, sepsis, infertility as well. You do want to educate the patient on safe sex practices. Patient will need to be rescreened about 3 months after treatment is completed. Short and long-term consequences can occur, like we talked about. PID nursing assessment, like we said, often asymptomatic at first, but if it goes untreated for a very long time, then we're going to start to see symptoms. And we're going to start to see symptoms like vaginal discharge, menstrual irregularities, painful urination. Another word for that, I put it there. It's just dysuria. It's just a fancy word for that. Dyspareunia, lower abdominal pelvic pain and tenderness that occurs after menses that may increase with voiding or with defecation. And then, since it is, a sexually transmitted infection, you may see a fever, general malaise, anorexia, nausea, headache, and possibly vomiting. So this patient's is going to feel very sick. They're not going to want to eat or anything. And then pelvic examination. So upon pelvic examination, there's going to be intense tenderness, may be noted on palpation of the uterus or movement of the cervix. Treatment. So all the same things we said up there. So broad spectrum antibiotics, treat sexual partner to prevent reinfection, analgesics for pain relief because they're going to be in a lot of pain, comfort measures like a healing pad, adequate rest and nutrition, and then just the same things as you said before, how to prevent reinfection, abstinence during treatment, importance of partner notification treatment, safe sex practices, and follow-up performance. So this is just repeating itself. Next is a uterine prolapse. I'm just going what's on the blueprint. Next is uterine prolapse. So these are all the structural disorders. You can have a prolapse on different organs wherever in the body, but here we're going to be focusing on a uterine prolapse. So the picture down here is a uterine prolapse. So that's the uterus, and the uterus is protruding into the vagina. And this is caused by weakening of the pelvic floor muscles and ligaments. So normally it's supposed to be up over here. Now there's a weakening of that pelvic floor muscles and ligaments. Remember what ligaments do? They connect bone to bone. So yeah, a pelvic organ prolapse, you can have there's different types of prolapses. So it's basically when one or more pelvic organs fall down or slip out of place. So that's what's happening with the uterus. It's falling down out of place and it's protruding out of the vagina. Risk factors can include childbirth and pregnancy, obesity, chronic constipation, decreased estrogen. Treatment, Kegel exercises. Remember what Kegel exercises do? They cause the pelvic floor muscles to contract, and that's very good. We don't want it to relax, as that can actually cause uterine prolapse. Intravaginal estrogen, just because we said decreased estrogen can cause that, so estrogen can help. Surgical repair, vaginal pessaries, which is a small removable device placed inside the vagina and provides support to the bladder, uterus, or rectum. And these are just different types of pelvic organ prolapses, but the only one on the blueprint was this one. Next is ovarian cyst. I'll show over here. So the ovaries are a common site for cysts. So remember what the ovaries do. There's two ovaries. And basically the ovaries, they are the site where the eggs are produced, and during ovulation they get released and they go down the fallopian tube, hoping to mate with a sperm, and then implantation can occur that way. So we have two ovaries, and the ovaries are a common site for cyst. So cyst can be a simple enlargement of normal ovarian structures, abnormal epithelial growths. So these are usually benign, but must be evaluated to rule out ovarian cancer, especially in postmenopausal women. So older women who've been through menopause already. Signs and symptoms include asymptomatic or may report acute chronic abdominal pain. Ruptured cyst symptoms may mimic appendicitis. So remember, appendicitis is like that right lower quadrant pain, McBurney sign, things like that. Ectopic pregnancy, large cysts, abdominal swelling, pressure on nearby organs. And this is post-op care after the cyst is removed. So care is similar to abdominal surgery, unique risks, abdominal distension due to sudden drop in intra-abdominal pressure from cyst removal. Surgical decision-making, hysterectomy may be discussed if bilateral ovarian removal is done for a suspicious mass. So hysterectomy is when they remove the uterus. Like if there's a complication like ovarian cancer or any other type of complication where they need to just completely remove the uterus. Polycystic ovary syndrome is known as PCOS. This is a common disorder that's characterized by a hormonal imbalance and the formation of cyst. So, typos. A small fluid-like sacs in the ovaries. So it's a hormonal balance. Basically, it's affecting the ovaries, causing cyst on the ovaries. It involves dysfunction in the hypothalamic pituitary ovarian axis, and what this results in is chronic anovulation, hyperandrogenism, so high levels of androgen. And androgen is referred to as male hormones, but all females produce a small amount of it. So high androgen levels prevent ovulation, which in turn causes development of cysts in the ovaries, and it results in some of the symptoms like hirsutism is just when women start to grow like male-like hair, and then acne as well, and then multiple small ovarian cysts. Chronic involution. This just means a lack of ovulation. So the woman is just not ovulating, and if a woman can't ovulate, then she can't, get pregnant. Affects 6 to 20% of women of childbearing age. Clinical features of PCOS: androgen excess symptoms. So we just said, androgen is normally found in men, but here with PCOS, there's an increase in androgen in women. Like, we're supposed to have a small amount, not a high amount, like in PCOS. So we see hirsutism, which is a male pattern hair growth on the face or body, acne that may be difficult to treat, and then alopecia as well. You're going to see menstrual irregularities because, like we said, there's going to be anovulation. So there's not going to be like ovulation happening like it's supposed to. So there's be missed periods, fewer periods, or maybe even more frequent periods, or no periods at all. So there's just going to be a lot of menstrual irregularities. Infertility can also occur because if you can't ovulate, then that egg is not being released from the ovaries. Obesity, difficulty losing weight, because PCOS can cause weight gain. Insulin resistance and glucose tolerance, and this is particularly in females who are overweight. Dyslipidemia, so the high LDL levels, which can be very dangerous. And then sleep apnea, and then increased risk of anxiety and depression. Diagnosis of PCOS. So the diagnosis of PCOS, you need 2 out of 3 of these to actually diagnose it. So you're going to do a physical exam and then a pelvic exam as well. So you're going to see swollen ovaries if you do a pelvic exam, because remember, PCOS are those cysts on those ovaries. So you're going to see hyperandrogenism, which, remember, that is just you do a blood test and you see high levels androgen, which is not normal in women. We're supposed to have a small amount, not a high amount. We're also going to see chronic anovulation, which is irregular periods. This woman is most likely not ovulating the way she's supposed to, or maybe it happens not monthly, maybe every couple months, where she have a normal period, but they're very irregular. Polycystic ovaries on the ultrasound, so multiple cysts on one or both ovaries. Long-term risk, type 2 diabetes, because we talked about that manifestation of the insulin resistance. Cardiovascular disease, because we talked about dyslipidemia, is also a symptom. Non-alcoholic fatty liver disease, endometrial cancer, and this is due to unopposed estrogen from chronic anovulation. Medical management, there's no cure, but symptoms improved with weight loss and medications. Cure symptoms improve with weight loss and medications. Weight loss can help reduce insulin resistance, regulate menstrual cycle, and improve your chances of getting pregnant. Lifestyle changes is usually the first line, especially like weight loss, just so the symptoms aren't worse. Oral contraceptives regulate cycles and reduce androgen levels. Metformin, because of all those. Remember, metformin is that oral anti-diabetic medication. It improves insulin sensitivity, reduces androgen levels, help regulate cycles, and promotes weight loss. And then clomiphene citrate is used to stimulate ovulation if pregnancy is desired. All right. Endometriosis was also on the blueprint. So the thing with endometriosis, this is when we have the growth of endometrial tissue, which normally lines the inside of the uterus. So it's actually growing outside of the. I don't think I sent the notes. I'm just gonna email it to whoever's here. I'm gonna post it in the chat real fast. Okay, I posted it. So endometriosis, this is when we have the growth of endometrial tissue. So remember that the inner lining of the uterus, that inner lining is called the endometrium. So the endometrium normally thickens, and then if you fail to get pregnant, then we have our period. So that's the whole thing with it. But if you are pregnant, then the endometrial lining will thicken up and it will stay thickened up for that whole 9 months. So that's what the endometrium is. So here, what's happening is that, normally we're only supposed to have our endometrial lining within the uterus, but now it's growing other places. So now it's growing outside of the uterus. We can see it now lining over the ovaries or the fallopian tubes or the tissues lining your pelvis, which isn't normal. Because you want to think that, when we get our period, like right before we get our period, that lining is super, like inflammation's going on, it's thickening up. So of course, this patient's going to be having pelvic pain, dysmenorrhea, and it is a common cause of infertility as well. The most common findings are pain and menstrual irregularities. So you're gonna be having pain in the lower abdomen because you want to think inflammation, because you have an inflammation that's outside of the uterus now, which is not normal. Lower back, pelvis, rectum, or vagina. So pain that occurs during sexual intercourse or while defecating. Because you are having inflammation like around those pelvic organs as well, maybe in the cervix as well. So that's why it's painful. Menstrual, so abnormal menstruation, heavy menstruation, irregular menstruation, painful menstruation, or spotting. So you just have the menstrual period is all out of whack. GI, constipation or nausea, abdominal fullness or cramping, just because there's so much inflammation going on. So now this lining is lining other organs. Also common is infertility, but it's not impossible if someone has endometriosis, just because they do also have that endometrial lining within the uterus as well. It's still there. It's just now we have that lining other places as well. It's a common cause, but it can still be possible. So because that endometrial tissue is not growing in the right places, we need that endometrial tissue to be nice and thick, appropriate for implantation. So the diagnostic treatment and how we're gonna diagnose endometriosis is that you're gonna do the pelvic exam. And then you're gonna do an ultrasound, MRI, but the definitive diagnosis is doing a laparoscopy. So a little bit about treatment. So we're going to do supportive care. So mainly you just want to treat the symptoms. This patient is going to be having a lot of pain. Patient education related to treatment and side effects, medication. So definitely analgesics, just because it is signified by a lot of pain. And then pain and inflammation relief, just because now there's inflammation happening, all over by the pelvic organs. Hormone therapy, so hormonal contraceptives, which will stop periods and reduce estrogen. Gonadotropin releasing hormone agonist, an antagonist which will decrease estrogen, and it's known as a temporary menopause. So just preventing this woman from getting her period, because when they get their period, it's going to be like very intense pain, just because now you have inflammation not only within your uterus, but now you have bleeding that's happening within the other organs as well, because that lining has to shed normally. And these are just some of the other medications, but mainly it's just like treating it. If they want to stop their period just to prevent that pain from happening, then they can do that. Right. Next is human papillomavirus, which is known as HPV. This is the most common sexually transmitted disease among sexually active young people. So there's different strains of HPV, which can cause genital warts, and others can lead to cancer. So HPV is the most common cause of cervical cancer. So HPV is the primary risk factor for cervical cancer. HPV is preventable with vaccination. So vaccine should be administered prior to first sexual contact. So first dose is around age 11 to 12, and then the second dose will be 6 to 12 months later. And then treatment of those genital warts, if there are, and then associated with cervical dysplasia and cervical cancer, so need annual Pap smears. Typically asymptomatic, people unknowingly spread it to others, so it is pretty common. So for HPV strains that cause genital wart, signs and symptoms include white or flesh-colored growths in the genital region of the oral cavity. Diagnosis is going to be a Pap smear. So Pap smears, they're usually done every 1 to 3 years, but it just depends on the risk profile of the patient. So you have a family risk factor of cervical cancer, you'll maybe get it annually, but if not, every 3 years. Positive colonoscopy and cervical biopsy can be used to assess for cancerous or precancerous cells in the cervix. Treatment of HPV, no cure for the virus. External genital warts. So there's no cure for the virus, but say if you are getting those external genital warts, like on the genital area, then they can do like that, like a cream, a topical application, or if it's like severe, we can do a surgical removal. But the main thing is just for prevention. So vaccinate boys and girls at age 11 or 12, cervical screening. So those Pap smears do catch it early on. And then patient teaching as well about HPV. So partner notification is very important, safe sex practices. More frequent Pap tests are likely to be necessary going forward. If they're at high risk, instead of every 3 years, annually, or go more frequently to get tested. Just looking what's next on the blueprint. Breast cancer. Okay, so breast cancer is a cancer that develops in the breast tissue, usually as an adenocarcinoma in the glandular cells of the breast. Screening for breast cancer is done through mammograms. So it's usually recommended that patients start getting mammograms annually at age 40, in addition to monthly breast self-examinations. So patient teaching is very important, especially on teaching a woman on how to do a breast self-examination. If a patient is at higher risk for breast cancer because of family history, they may need to undergo a baseline mammogram starting at age 35. Risk factors, several risk factors, genetics, early menarche, which just means like you got your period early on, or a late onset of menopause. Other risk factors include long-term use of oral contraceptives, hormone replacement therapy, smoking, and obesity. Signs and symptoms of breast cancer. There are some signs and symptoms of breast cancer that are important to look out for, because it is important for them to do self-examinations. If there's a lump, it's better to catch it early. All right, and then other symptoms include dimpling over the skin of the breast, nipple retractions, or an ulceration, or if there's discharge also coming from the nipple. Treatment, there are several treatments for breast cancer depending on the type and severity. And these are just a couple of the medications. Mastectomy would be the surgery, or a lumpectomy. All right. Just gonna move on to the male one. It just says prostate and testicular disorders. So I'm going to go to BPH. All right, benign prostatic hyperplasia. So that's enlarged prostate. So just going over the anatomy and physiology. So, your prostate, basically, a male's prostate surrounds the urethra, and urethra is associated with the urinary tract. So, it goes from the bladder down the urethra, down the ureters and then to the urethra. So it surrounds that. So if we have an enlargement, then we're going to have a lot of problems with getting urine out. So that's the main thing going on with BPH. So yeah, the prostate gland sits below the bladder and surrounds the urethra. So we have enlargement of the prostate gland, then they block the outflow of urine, and we end up with urinary symptoms. So it affects half of men older than 40 years of age and 50% of men older than 60 years of age. Overall, it's just very common disorder in men because of a change in hormone levels. Manifestations are those of urinary obstruction, urinary retention. And whenever you have urinary retention, urine is just sitting in the bladder. It's not moving out of it. It becomes very stagnant. And whenever anything becomes stagnant, it's like the perfect site for bacteria to grow. So that's why urinary tract infections are very common. And then post-void dribbling. So if you ever heard of post-void residual, like in the hospital, urine is just like sitting in the bladder even after the patient has voided as much as they could, but there's still urine in the bladder. Hematuria, so blood in the urine, excessive nocturnal urination, and then sometimes in some cases frequency or a sense of incomplete bladder emptying, incontinence, urine to urinate and leaking, and sexual dysfunction. But the main thing with this one is that there's just a lot of urinary retention, especially if it's like a very high lab number. The PSA levels are very high and that prostate's very enlarged and no urine is coming out. So we're definitely going to see a lot of urinary retention and UTIs. It does develop over time. So changes in the urinary tract are slow and insidious. So symptoms depend on severity. So dysuria, hesitancy, sensation of incomplete bladder emptying. Diagnosis is going to be a digital rectal exam. They put a finger in the rectum and palpate the prostate gland through the rectal wall, and they check for enlargement. Urine tests to rule out an infection or other conditions that cause similar symptoms. And then labs would be the most important. So a prostate-specific antigen level will be drawn. So PSA levels are expected to be under 4. So if over 4, that's indicative of BPH or prostate cancer. That's why further evaluation needs to be needed. But also with labs, we also want to do like a CBC just to look at the white blood cells. If it's elevated, patient may also have a UTI. UTIs are common with BPH just because of all that urinary retention. And then creatinine and BUN may be elevated with kidney involvement. Management of BPH, so 3 key meds. Probably heard of tamsulosin, which is a main one. But there's also finasteride, which is an androgen inhibitor that prevents conversion of testosterone. And this in turn results in decreased size of prostate gland. So all this does, it prevents hormonal changes that are causing the prostate to have that overgrowth. But it can take 6 months of work just because it is preventing hormonal changes. This one is an alpha-1 blocker. So if you think back to PHARM, so alpha-1 is responsible for vasoconstriction of our arteries. But if we're blocking that vasoconstriction from happening, now we are causing dilation. So that's what tamsulosin is all that's doing. It's causing a lot of vasodilation. And if we're causing a lot of dilation where there's, an enlarged prostate, constricting urine flow, and now we're dilating, this is going to, relax the muscles in the prostate gland, and this is going to facilitate urine to have better, flow out through the urethra. Tadalafil, erectile dysfunction med, that is also used in treatment of BPH, and it works by relaxing the muscle cells in the prostate gland. So it just relaxes the smooth muscles. But the main one here that you guys probably all heard of is tamsulosin. This is one that you'll most commonly see with BPH. Alpha-adrenergic blockers, that's just tamsulosin. Measures to reduce pain and spasms, and a catheter for acute condition. especially if that patient is unable to avoid. Surgical treatment, if medications are unsuccessful in treating the urinary symptoms associated with BPH, surgery is also an option. So this surgery is called TURP. So it's a transurethral resection of the prostate. Basically all it is that an instrument is inserted into the urethra and excess tissue is cut away from the prostate in order to restore urine flow. Then a 3-way urinary catheter is placed in order to provide continuous bladder irrigation. This is a little bit about the surgery, but usually tamsulosin would just like correct the problem and like dilate so that proper urine flow can occur. I think it says testicular disorders. These are different testicular disorders. It's just here if you just want to read through it. I'm not sure if that's going to be on the test that much. I'm just going to go to, I'm just going to skip to hematologic and then I'll go over musculoskeletal after. So this is management of patients with non-malignant hematologic disorders. So anemia, blood disorder that results in decrease in RBCs or a decrease in hemoglobin. So lower than normal hemoglobin and fewer than normal circulating erythrocytes, which is a sign of underlying disorder. So yeah, we have low hemoglobin, and remember what hemoglobin does, it carries oxygen, to perfuse our organs, perfuse our extremities. So there are 3 main causes of anemia. So blood loss. So if a patient has experienced a lot of blood loss, or if there's insufficient red blood cell production, or if there's excess destruction of RBCs. But no matter the cause, we end up with decreased oxygenation to the body's tissues. So blood loss can be because of GI bleeding, trauma, menorrhea, and then the next ones are hypoproliferative, which is a defect in the production of erythrocytes. This is caused by iron, vitamin B12, or folate deficiency. Decreased erythropoietin production, cancer, or bone marrow damage. So the most common one would be iron deficiency anemia. So an individual has insufficient intake or absorption of iron. It is common in pregnant women if they're not intaking enough iron. Also in children, especially we see this with toddlers, just because they drink a lot of milk, that'll make them super full and they don't want to eat any food that are rich in iron. So that's why iron deficiency anemia is really common in children. All right, just repeating itself. Vitamin deficiency anemia. So this is the insufficient intake of folic acid or B12. With pernicious anemia, the individual lacks something called intrinsic factor in their gastric mucosa, and this intrinsic factor allows for absorption of B12. So we can't absorb B12 with pernicious anemia if there's no intrinsic factor, so there has to be a different route, usually parenterally. Aplastic anemia is bone marrow damage that occur based on cancer or autoimmune disorder or medications. And then hemolytic is the destruction of erythrocytes. Can be genetic. So here we'll see sickle cell disease. Manifestations of anemia, it just depends on the development, duration, problems, all things like that. So mainly, fatigue, weakness, because you want to remember that, we don't have these hemoglobin that's going to be carrying that oxygenated blood cells around to the body and to the organs. So of course we're going to see fatigue and weakness and pallor. Cardiac system, we're going to see tachycardia, orthostatic hypotension. Respiratory system, you're going to see dyspnea on our exertion, decreased oxygen saturation. Neuro, you're going to see fatigue, increased need for sleep. There's going to be some GI symptoms. Skin's going to look very pale, cool, mottled, delayed capillary refill, unable to tolerate the cold, tongue changes, nail changes, angular cheilitis, pica, diagnostic test, really we just want to look at a CBC and just look at all these levels, especially like your hemoglobin, hematocrit, what is the, and then you want to see like what the underlying cause. If there's low iron, then it's iron deficiency anemia. Low B12, then there's low B12, so things like that. Medical management of anemias, you want to correct or control the cause. Administer oxygen. Transfusion of packed RBCs. Treatment specific to the type of anemia. Dietary therapy, and then depending on the cause, if they need iron or vitamin supplements like iron or folate or B12. All right. If it's aplastic anemia, erythropoiesis, which helps to increase the amount of RBCs, transfusions like we just said, and then immunosuppressive therapy. All right. We already said that. Problems, heart failure, angina, because there's not enough oxygenated blood, enough hemoglobin, going to organs. All right. Planning and goals for the patient with anemia, decrease fatigue, attainment or maintenance of adequate nutrition, maintenance of adequate tissue perfusion, very key. Compliance with prescribed therapy and absence of complications. Right. It's just saying the same thing here. You have your hemolytic anemias like sickle cell disease. So this is genetic. Someone will have this their whole life. Autosomal recessive genetic disorder. So autosomal, one parent is a carrier. It doesn't mean that the parents have it, but one of the parents is a carrier. The patho behind it is just that, normally we have nice and round red blood cells, but here we have sickle-shaped hemoglobin. And they're not as adequate as normal round ones are, so there's going to be decreased perfusion, everything like that. Risk factors, family history, African American, Middle Eastern, signs and symptoms are all the same that we talked about before. Pallor, pain, fatigue, except for something that we're talking about, vaso-occlusive crisis. So basically something will cause a vaso-occlusive crisis in someone who has sickle cell disease. Most likely it's going to be dehydration, which is the most common cause. And that will cause these sickled C-shaped cells to clump up and occlude an artery, and it will prevent blood from getting to an extremity and perfusing it. So that's why we'll see chest pain, respiratory distress, shortness of breath, pallor, all things like that. Assessment of the patient with sickle cell disease, health history, pain assessment. Usually these patients are going to be in a lot of pain, especially if they're experiencing a vaso-occlusive crisis. Laboratory data, you're going to look at those hemoglobin cells, electrophoresis, and see the S or like C-shaped hemoglobin. Presence of symptoms and impact of those symptoms on patient's life, swelling, fever, pain, sickle cell crisis assessment. So when a patient has sickle cell anemia, they will often experiencing crisis, and there are several crises to be familiar with, but the main one is vaso-occlusive crisis. The patient will have severe pain that will need to be treated with opioid analgesics, because it's like they'll rate it like a 10 out of 10 pains. They're going to be in a lot of pain with a vaso-occlusive crisis. So there's going to be certain exacerbations. I forgot to put dehydration, hypoxia, exercise, high altitude, fever. The decreased blood flow to the tissues lead to hypoxia, ischemia, and infarction. So basically something caused it, a precipitated event caused it, and then now they're experiencing decreased perfusing to an extremity because these cells are just clumped up. Now they're preventing blood flow from getting to an extremity. So of course you're going to be in pain. There's decreased perfusion to, maybe the foot. Or maybe a vaso-occlusive crisis happened near an artery near the lungs. Now that they're having shortness of breath. So there's decreased perfusion to the lungs. It just depends where it's happening. There's severe joint pain if it's happening, within the feet. They may also have swelling in their hands and feet during this type of crisis. And then there's other types of crises which aren't as common as a vaso-occlusive crisis, but you have splenic sequestrin crisis, which is blood flow is blocked out of the spleen due to that sickling of the RBCs, and this causes enlargement of the spleen. So basically, it's just that the blood pools in the spleen, and it pools all the way in the spleen. So you have enlargement of the spleen, hypovolemia, because all the blood is in the spleen, and shock. Aplastic crisis, severe anemia that's typically related to a viral infection. So if they get this is only if they get like a viral infection and then the blood cells drop. Acute chest syndrome, blood flow to the lungs is impaired. So we have, shortness of breath, fever, and cough. Hyperhemolytic crisis. This is when you have a extreme rapid drop in hemoglobin levels due to accelerated hemolysis. All right, diagnostic. Sickle turbidity test, which will detect the abnormal hemoglobin. That HBS, you'll see that sickle hemoglobin electrophoresis, which they normally do like when children are like babies. Usually this is caught like relatively early on. Chronic skin ulcers of sickle cell. So yeah, there's going to be decreased perfusion to an extremity, especially with a vaso-occlusive crisis. Then that can happen. Collaborative problems and potential complications, hypoxia, ischemia, infection, dehydration, CVA, anemia, acute and chronic kidney disease, heart failure, impotence, poor compliance, substance abuse. Substance abuse because these patients are going to be on opioids a lot because they're in severe pain. So there's always a risk for these patients becoming substance abusers and very reliant on opioids. Interventions for the patient with sickle cell disease, pain management, like we said, opioid analgesics on a schedule. Hydroxyurea, which increases production of fetal hemoglobin. IV fluids. Remember, because dehydration can make the symptoms worse, making the blood thicker, not letting blood flow nicely to the extremities. Because you want to try to help the flow of the blood get to the organs, which will help prevent hypoxia. Blood products and oxygen is ordered, manage the fatigue, infection prevention, coping, education, disease process, monitor for complications, things like that. Next is polycythemia. So this is an increase in RBCs. There's different types here. The main thing with it is that, if you have an increase in RBCs, there's so much within the blood now. So it makes the blood thicker, which puts patients at risk for clots. That's the main thing with this one. And patients at risk for ischemia with that. So they'll have like a ruddy complexion, dizziness, headache, fatigue, clubbing of fingernails, enlarged spleen. Diagnosis, medical management, no cure, treatment not needed if condition is mild, treat underlying cause, things like that. Bleeding disorders, you have thrombocytopenia. This is a condition marked by decreased platelet counts because platelets help the blood to clot. The lack of platelets seen with thrombocytopenia puts the patient at very high risk for bleeding. So, your normal range, but it's going to be low. Patients at risk for bleeding, so we should take certain precautions. So as the nurse, you want to monitor the stool, the vomit, all things like that, but also avoid IVs or IM injections because, they are a risk for bleeding. So if you do that, then they're going to continuously bleed. So anything that can, have a patient harm the patient or the patient falls. We just want to prevent any type of bruising or anything. Patient teaching, use a soft toothbrush because you don't want those gums to now bleed. Avoid blowing their nose vigorously. Avoid taking NSAIDs because remember, NSAIDs can cause GI bleeding. Avoid falling. All things like that. Acquired coagulation disorders. Coagulation disorders caused by a deficiency in platelet and unclotting factors, which increase. All right, so now we're talking. Include excessive bleeding or bruising, oozing, fatigue, tachycardia, hypotension. All right, let's go to DIC. DIC is a little bit complicated, but it's a disorder where clotting factors and platelets are depleted through the formation of microclots. But it's not a disease, but a sign of an underlying disorder. Usually, like pregnancy can cause DIC. Certain things can, like a trigger. We have a precipitating event. So it could be sepsis, it could be trauma, it could be shock, it could be cancer, abruptio placentae, toxins, allergic reactions, blood transfusions, all these things that are triggers. So you have a precipitating event, which sets off the cascade of actions where the proteins in the blood can no longer control bleeding or clotting. So we'll have a precipitating event. It starts this whole entire process where we'll have excess thrombin, which excess thrombin, if we have too much, then we have excess clotting. So we're going to have, this patient may have clots going around the body. It may cause a stroke. It may cause a heart attack. But on the other hand, once we use all those clotting factors, because it's like increased highly, we're eventually going to use all those clotting factors and everything like that. And then the patient is going to start to bleed. So this disorder is characterized by clotting and then bleeding. So both. All right. And these are the symptoms you're going to see. So clotting and bleeding are both things that are occurring here. First, you're most likely just going to see clotting. And then once all those clotting factors get used up and there's no more clotting factors to be used up because we were just using all of it, now we're going to see bleeding. So clotting, you may, see, especially if a clot is occluding the lungs or the heart, that's what you'll see. So we all know those signs and symptoms. Legs, if we see a DVT, you see pain, redness, warm, swelling, and it'll be unilaterally, right? Brain, so if we're dealing with a cerebrovascular accident, a stroke, then you can see a headache, speech changes, paralysis, dizziness. So that's what we want to be on the monitor for. And then bleeding, once all those clotting factors are taken out, then we can see all these bleeding signs and symptoms. Next are laboratory tests. So, of course, we're going to see a decrease in platelets, but we're also going to see a decrease in fibrinogen, and that's due to an excess thrombin. Just here. Because we were using up all those clotting factors, we are going to be using up all of the platelets. Platelets are going down, contributing to bleeding risk. But we are actually going to see an increase in PT, APTT, and D-dimer. Clotting time goes up, taking client long time to form a blood clot, and that indicates high risk for bleeding. D-dimer is non-specific lab that tells me somewhere in the body we have a clot going on, but we don't know where or how big. It just tells you if there's a clot. Right, so high D-dimer means clots. All right. So you're just going to see both signs and like laboratory tests indicating that there's clotting going on, but now there is actually bleeding going on. So usually you'll see clotting first and then bleeding right after. And then treatment, you want to treat the underlying cause, correct the tissue ischemia, replace fluids and electrolytes, maintain blood pressure, and replace coagulation factors. Use heparin, if we're dealing with more so clotting. It just depends. Is this patient, are we seeing more clotting or are we seeing more bleeding? All right, this is just repeating. All right. These are the cancers. I'm going to go to musculoskeletal real fast. All right, so we have injuries of the musculoskeletal system. So the main ones would be like a strain, which is a pulled muscle injury. So this is dealing with a muscle. And then, which is most likely like dealing with like a tendon problem, And then sprain is when the ligament tears. Ligaments is what connects bone to bone. Dislocation is like a complete loss of contact between two bones. So like, your elbow is a joint, but say it gets like out of place completely, then that would be a dislocation from those bones. A subluxation is like the same thing as a dislocation, except that it's a partial loss of contact between bones. Involution is a complete separation of a tendon or a ligament from its attachment, which is definitely not safe because tendon is what connects muscle to bone, but a ligament is what connects bone to bone. So that it's definitely not good. All right. Management of soft tissue injuries, so like a sprain or a strain. It's gonna be you're gonna rest, ice, compression, elevation, and immobilize. So the patient may even need a cast. Next are fractures. There's different risk factors. Maybe the patient has osteoporosis, Paget's disease, long-term steroid use, substance abuse, trauma. Maybe they fell. Maybe they have bone cancer, all things like that. So different types. You have closed or simple. So this is no break in the skin. Open or compound complex. This is when there's a fracture, but it breaks the skin surface, and you can sort of see it now too. So this is actually a high risk. This patient will be at a high risk for infection because now you have a bone protruding out of the skin. So that's something we have to focus on here. And it depends on what level it is and how we're going to really treat it. Types of fractures. There's so many different types here. I just highlighted the main ones down here. You have a stress fracture. Bone is exposed to repeated stress. And there's a little example down here. Another one, main one would be a green stick fracture. It's a partial fracture. Only one side of the bone is broken. Right there. And then you have stress one we talked about. Spiral is one that is most common with like child abuse. So it's telling me that someone has like twisted this child's wrist or something and caused a fracture. So this one is indicative of child abuse. That's open, so it's protruding out of the skin. Green stick is a partial one. Epiphyseal one is when the fracture is now near the epiphyseal plate, and especially if it's a child, this is alarming just because epiphyseal plate needs to be closed when the child is done growing. But say they're not done growing and there's a fracture, we need to make sure that this heals properly so that the child can finish growing appropriately. And you have compression fracture. Something compressed it. That's why that's happening. Comminuted. There's multiple like fragments of the bone. That's what's happening there. All right. Manifestations of fracture: acute pain, local swelling, loss of function, deformity, muscle spasms. Muscle spasms do happen with fractures. Shortening of the extremity, crepitus, so that like grating sound. Medications, analgesics for pain. If it's an open fracture, we're going to want to do antibiotics just to prevent infection. If this patient is getting muscle spasms, then we're gonna do muscle relaxants, just because we really do need this fracture to just be immobile and not move it so it can heal properly. Emergency management of a fracture: cut the clothing away from the area, remove jewelry, control bleeding if there is bleeding, and immobilizing the fracture through splinting. Immobilize the body part. Splinting is joints distal and proximal to the affected fracture site must be supported and immobilized. And then you're going to want to assess neurovascular status before and after splinting. So remember the 5 P's. Neurovascular check, patient's pain, sensation, skin temp, color, capillary refill, pulses. And you want to see if they can move their extremity. All right, medical management of fractures. So if it's a fracture reduction, this is what a fracture reduction is we restore fracture fragments to their normal anatomic alignment. If we do a closed reduction, which is non-surgical, bones are manually repositioned without cutting the skin. So it's sort of like in the TV shows when they say 1, 2, 3, and then they move the bone where it's supposed to be that way. And then you have, these are the methods for it. So they'll do that, or they'll put it back in place, and then it's followed by immobilizations. Patient's going to need a cast splint or traction. Open reduction is when they surgically put the bone where it's supposed to be, and then we're going to allow healing with a cast. Immobilization, we want to immobilize the bone so it can heal properly. You can do casts or splints. Internal fixation is when they put screws, pins, and rods in place. They're actually inserted into the body to stabilize the bone. And this is for, open fractures, or if it's more severe. External fixation is when the screws and pins are inserted into the bone and attached to an external frame outside of the body for stabilization. All right. Techniques of internal fixation. Factors that affect fracture healing. Age, medications, they're all here. Complications of fractures. Early complications would be like shock, especially if it was an open fracture where, maybe sepsis has happened and septic shock has happened or bacteria came in. Osteomyelitis is a bone infection. So if you remember from Pete, so we went over that. Fat embolism. This is when a fat globule that comes out of the bone marrow in the bone and travels up into the lungs. So it causes shortness of breath, confusion, tachypnea, tachycardia, things like that. Treatment is most likely going to be supportive, so bed rest, IV fluids, and oxygen. Compartment syndrome is a main thing, especially if a patient is in a cast. Compartment syndrome can happen. It's a complication. So there's an increase in pressure in the muscle compartment that impairs circulation to that extremity. So there's so much pressure, and maybe that cast is too tight, and now there's no circulation going to the extremity past where that cast or splint is. So what you need to do as the nurse is assess the neurovascular and do the neurovascular checks. So you check for pain. Are they having pain with movement that's unrelieved by medications? Pain is expected, but it's not supposed to be too intense. But it's also supposed to not be there. Some patients, if they say they're not having pain at all, that's not normal either, just because they are supposed to be in a certain amount of mild pain. Paresthesia is that numbness and tingling sensation. With paresthesia, you're mainly, you're checking their sensory neurons. So you're checking sensation. So can they, when you touch their foot, distal to where the injury is. So remember, proximal and distal. Distal is after the injury, below it. You're check distally, touch the patient and ask them, can you feel me? Do you feel numbness? Do you feel tingling when I touch you? And if they say yes, that they can feel you without numbness and tingling, that's a good sign. But say they can't really feel you past site of injury, that's not good. Or if they feel very numb, they can't feel anything, that's not good. That's telling that there's poor sensation and there's poor blood flow getting through that extremity. Paralysis is testing motor neurons. So can they move? Pallor is the skin pale. Pulselessness as well. So all these things are, if the patient reports all these things, it's telling me that there's not enough perfusion going on to the extremity. The affected extremity will also be hard and swollen. If you suspect your patient's compartment syndrome, you absolutely do not want to apply cold to the area. Remember, cold causes vasoconstriction. Heat causes vasodilation, right? And if you're vasoconstricting something, then that's certainly not going to get blood flow flowing the right way. And then also do not elevate the extremity because that would also impair circulation to the extremity. Notify the provider. Treatment is going to be a fasciotomy where they perform a deep incision into the muscle compartment to relieve that pressure. And then if it's very serious, then an amputation. Also, early complications is going to be a blood clot, venous thromboembolism, pulmonary embolism. Delayed complications are all here, but the main ones is the ones I talked about. And these are just different types of fractures. Different types. All right, and then this is dealing with all the casts. So even with casts, we also do neurovascular checks. So pain, pallor, pulselessness, paresthesia. This is all just saying the same thing. And then complications. So acute compartment syndrome, like we talked about. Those the complications that we talked about with fractures are actually complications with braces and cast as well. Because after a fracture, they're going to be in a cast or splint. Disuse syndrome, muscle atrophy and loss of strength, pressure injuries. So these are all very common sense, complications. And then these are just the devices. And the main thing with these devices is that we really just want to keep these bones in place, and we want them to become immobile just so that they can heal properly that way. And that's also what traction does as well. it aligns the bones in place and immobilizes it so it can, heal properly. It's all just, and then you have skin traction, which goes to the skin, but skeletal traction is more invasive. It goes to the bones. Halo traction is if there's like a cervical spine fracture. So that one is like it looks like a halo on top of their head, and this one's super uncomfortable for the patients. And these are all like the nursing interventions. For traction, like you never want to adjust the weights. You have to care for the pins that are inserted into the bones or on the skin. So you care for like the pins that are inserted. That's really it though. Let me know if you have any questions.